Let's begin by reviewing the key activities of the RCM front end, which covers everything that happens before the episode of care itself. Much of this stage is about understanding the patient and their likely treatment needs. However, what the HCP does, or fails to do, in the front end will impact their ultimate ability to collect earned revenue down the line. In this way, the RCM process begins at first point of contact, patient acquisition. Without acquiring any patients, it's difficult to generate revenue. Generally, there are three ways for HCPs to acquire patients. The most common is self-directed patient acquisition, when the patient finds the HCP, say via ZocDoc. In some cases, HCPs will actively look for patients, say to target a certain profile with a specific treatment. In these cases, they will use marketing for acquisition. When targeting specific groups, HCPs may develop an early sense of what their eventual patient mix might be, and what types of payers these patients may be covered by. For example, if targeting older patients, the HCP can expect and plan for more dealings with Medicare. Patients can also be acquired through referral networks. This is when multiple HCPs join together as a larger network and pass or refer patients between each other. This has a number of RCM-related benefits. For one, it helps retain patients and associated revenue within the broader network. Another benefit is increased record sharing between HCPs. This can minimize the risk of documentation errors and therefore reduce the risk of lost revenue due to faulty paperwork. Another benefit of being in larger health systems is greater negotiating power with payers. Larger health systems are often able to secure better rates and more timely payments. After acquisition, the next step in the RCM journey is scheduling. Scheduling is about getting the patient to the right HCP as quickly as possible. Timely scheduling is good for the patient. It's also good for revenue flows. After scheduling, HCPs prepare to give the patient price estimate, basically their best estimate of the end price. This will depend on the patient's profile, the anticipated treatment plan, and the payers involved. In the past, a price estimate was largely considered a nice-to-have. Today, this is increasingly a must-have. Out-of-pocket price estimates, called good faith estimates or GFEs, are now required in the U.S. by regulations like the No Surprises Act. While this is great for patients, providing these estimates can be a challenge for HCPs. Estimating the patient's total obligation, their share of the bill, requires input from any associated payers, like commercial insurance or Medicare. In many cases, HCPs have negotiated a separate price list with each payer. So, determining the correct likely price requires cross-referencing with the correct individual payer-provider agreements. Another complication is that certain procedures may be carried out by different HCPs, say tests sent to a third-party lab. The costs of these services can be less clear. When the patient arrives at the clinic or hospital, the registration step begins. Here, HCPs collect any additional personal information, medical history, and payer details. Getting the paperwork right is table stakes for getting paid. Any missing information can lead to a denial of payment. Plus, different payers establish different documentation requirements. For example, Medicare requires that HCPs provide a unique patient identifier called the MBI, Medicare Beneficiary Identifier number. Without this number, Medicare will not approve any payments. Since HCPs work with hundreds of payers, keeping track of which payers require what details and then recording them properly is no small feat. After the patient has been registered, the HCP begins eligibility verification. Here, HCPs verify the patient's details and insurance coverage. In many cases, the front end is considered complete after the HCP determines that a patient is covered for care. However, some payers require an additional authorization step for certain procedures. In these cases, payers will only agree to pay if they've given advanced approval. This is called prior authorization. Prior authorization has become a major pain point for many HCPs because it requires medical staff to manually request authorization from payers and wait for their response every time. When possible, this should happen before treatment is administered. HCPs do not want to administer treatment without knowing the payer is on board. In emergencies and during unplanned treatments, authorization might occur during treatment. While this isn't ideal, in most cases, payers will still pay, but it may delay the revenue collection process.